All right, so welcome everybody. Looks like the system is up now. So today we will start to talk about arrhythmias. Hopefully you watched all movies about arrhythmias. That should be around six movies. Now, and relatively, it's a very important part of ECG because the most of the use of the ECG is to diagnose arrhythmias, and this is the best tool to diagnose arrhythmias. First of all, we have to see what arrhythmia means. Basically, we call arrhythmia that is not rhythmic, not a normal sinus rhythm. So this is what we call arrhythmia. Arrhythmia can be when we do have a rate, so it's still rhythmic, but the rate is faster or slower, or whether it's regular or not, or whether the impulse is formed in the right place or not. Now, based on this, first of all, we have to uh, specify what the normal rhythm is. Basically, the impulse normally formed in the sinus node, and after is activating the atrium. Later on, the impulse reaches the AV node, where goes through the AV junction, and the bundle of His will activate the ventricle. So this is the normal way of the impulse formation. What can we say? First of all, we do see P wave in front of every QRS complexes. Now that's very important, and the last time we watched whether we do have P in front of the QRS is not. What does it mean? It meaning that the atrium activating first, and later on the impulse is propagates to the ventricle. But we have to have connection between the P and the QRS complex. How do we know that the P is initiated or atrial activation is initiated in the SA node? First of all, we know because when the sinus is activating the atrium, relatively, I think, yes, it's going. So it's meaning we do have a depolarization wave of the atrium that pointing from right to the left, because the SA node is located in the right atrium, very close to the vena cava. And this will generate an impulse that propagates from the right to the left. And if you are watching this vector, it's pointing toward the left side. And which are the left ventricular leads? Everything that located on the left side, including lead number 1, AVL, lead number 2, AVF. So these are all on the left side. If you're looking at the chest leads relatively, V6, V5, V4 is still watching at the left side. So by saying this one, we do have a rhythmically coming piece that the shape of the piece should be normal. It's meaning it's round and symmetric, all right? And it looks like the same in every bits if you following the P wave in each lead, looking at lead number 1, looking at lead number 2 or 3, that piece should be identical. And very similarly, AVR negative P and P in lead number 2 should be positive. Another very important one, that the heart rate within the normal range. It's meaning between 60 and 100. That's it. And another thing, that's because we do have a normal conduction relatively from the beginning of the P till the beginning of the QRS. This is what it says, the PR interval. It should be constant and ranging between 0.12 to 0.2. So these are all criteria that means that's a normal sinus rhythm. Now, Okay, I think I'm moving on because that was okay. Now, arrhythmia is different. Now, what can be the symptoms of arrhythmia? How do people, let's see, sensing the arrhythmia? First of all, a lot of cases there is no symptoms at all. The patient won't figure out anything. A lot of things that the palpitation or sustained irregularity or fatigue, the patient feel very weak, or dizziness, light headache, disorientation, and so on and so on. This can be from the sudden death or up to the sudden death can be the sign of arrhythmia. Now, okay, what can cause? You read it. I don't want to deal with this one. Now, the arrhythmias can be due to what we are discussing today, the impulse formation abnormality, that meaning that it can come, the impulse can come earlier or later, or not the sinus forming the impulse. And another thing that we deal with the next time, that we do have a normally formed impulse. However, the impulse is not propagating to the ventricle normally. And this is what we call the conduction abnormalities. Now, let's see the simplest when we discussing the arrhythmias based in time. Now, as you do see, this is the normal rate when the RR interval or the PP interval coming normally. We are talking about active impulse formation when the impulse came earlier than a normal. We call passive impulse formation when the arrhythmic impulse came later on. What does it mean? Let's see the simplest active arrhythmia, as you see here, when this red dot came earlier. So we do have a shorter RR interval followed by a longer RR interval. You already learned in physiology that is called a premature beat formation. Okay, so the early coming beat is a premature beat or extrasystole, that is still one beat only. However, if you do have consequently at least 3 or more beat that coming, it's called tachycardia because it's faster. By definition, the, this interval should be shorter than this or this interval. That's very, very important. Now, the this distance, the R1 interval, this is called the coupling interval, and the RR2 interval, that's called the compensatory pause. You learned in physiology, it's not a big deal. A later coming one, as you see in blue, when the R1 interval is longer than the RR interval, so that is called the escape bit. Now, if you do have at least 3 or more later coming bit that taking over the impulse, that's called escape rhythm. Now, let's talk about first the premature bit formation. Okay, first of all, this premature bit, every time it's coming earlier and followed by the compensatory pause. Now, based on the R1 plus the RR2, so the distance between a two normal bit and comparing to the normal rate, we can talk about undercompensated premature bit. What does it mean? It meaning that, as you see here, this compensatory pause cannot compensate this early coming bit. So the beat or this heart rate accelerated, so it make faster. Now, and another thing, if the compensatory pause exactly compensate, so this means that R1 plus the RR2 exactly equal with 2RR, that meaning that the compensated premature beat. However, if this compensatory pause was longer and made the heart rate slower, That means overcompensated premature beat formation. Now, why is it important to see whether it's undercompensated or compensated? First of all, you can determine where this premature beat coming from. Every supraventricle meaning that everything that outside from the ventricle, if this is the impulse formation center, such as, for example, the sinus or the atrium or the AV, that always undercompensated normally. Ventricle premature beat compensated. Now, however, this compensation, this recovery that the compensatory pulse does, it's depending on the oxygenation of the muscle. So if you do have some kind of problem with the coronary circulation, that could cause, for example, when you do have a atrial premature beat, that can be compensated or overcompensated, and that means that we do have a problem with the circulation of the atrium. Okay, there is another situation when we do have a premature beat, but exactly in the middle of this RR interval, that is called interpolated premature beat, such as here, for example, that's a ventricle interpolated premature beat. Now, these are the terminology, and this is what we can diagnose. Let's see the types of extrasystolias when we do have more premature beat subsequently coming. Okay, first of all, as you see here, that every second beat is a premature beat. That's a normal sinus, that's a premature. That's a normal sinus, that's a premature. That's a normal sinus, that's a premature. This kind of arrhythmia, it looks like rhythmic, but it's not rhythmic because the RR interval is not constant. This is what is called bigeminy. And for example, in this situation, we do have a ventricular bigeminy. Now, this premature beat can come not in the second, but in the third place. Every third beat is a premature beat. That's called trigeminy. For example, here as a quadrigeminy, or that's a trigeminy. So if a fifth one, that's a pentageminy, and so on and so on. So that's a allorhythmia. Now, we do have, in another way, we do have more than only one consequently coming premature beat. Such as here, for example, we do have two premature beats in a row. These are called couplets. When we do have two, it looks like that we do have a normal beats. And after these kind of beats called couplets. We can have three, for example, that the triplets or salves. This is another name of salves. But if we have more than three, we do have tachycardias. And that can be originated from the ventricle, it can be originated from the supraventricular area, and this is how it's called as a ventricular tachycardia or supraventricular tachycardia. And another terminology about these tachycardias, if it's coming faster and suddenly coming and suddenly goes away, that is called paroxysmal tachycardia. Or when we do have longer than 15 minutes, that's called sustained tachycardia. Now, basically, as you do see that the tachycardias, as I mentioned, I'm sorry, that's more than 30 seconds, that's a sustained tachycardia, and a non-sustained, that's the ending within 30 seconds, and a non-sustained or paroxysmal tachycardias. Okay, these are the terminology. Now, let's see what is the nomotopic impulse formation. So far, we were talking about when the impulse came in different times, earlier or later. Now, let's see, now we can talk about whether the impulse is coming from the sinus or not from the sinus. Okay, if we have an impulse that coming from the sinus, however, the rate is not the same as a normal one. We're talking about if it's faster than the sinus tachycardia, if it's slower, that's so the sinus bradycardia. And when we do have arrhythmia, that the sinus making the impulse, but irregular, that can be as a regularly coming, such as a respiratory or physiological arrhythmia, sinus arrhythmia, or sick sinus syndrome, and is coming differently. We can have a slower one when the sinus is not firing, and this is why missing one beat. The heterotopic one is not from the sinus, but can be from the atrium, for example, but can be from AV or can be from the ventricle. So these are the heterotopic impulse formation. What heterotopic means? Not from the sinus. Okay, let's see and let's talk about the sinus premature beat. We could have sinus premature beat when it meaning that the sinus will fire a little bit faster. So earlier is depolarizing the sinus node, and this is why we do have an early coming beat. How can we diagnose this sinus premature beat? First of all, we do have a P's in front of the QRSs, and that's PB identical with the previous one. So there is no difference between the P's. All right, that's be the difference when we do have an atrial one, and an atrial sometimes it's not coming from close to the sinus node, and this is why in any lead, maybe not in the same lead that lead number 2, but maybe in 3 or 1 or some other lead, you do have a different P wave morphology. This is one thing. So the P is identical, and another very important one, that the following beat, that compensatory pause or whatever, exactly same as a normal PP interval. So it's meaning that the PP1 and the PP is always undercompensated. And very, very important that these, maybe I'm making, I don't know, how can I do it? Yes, it's right here. Okay, so it's very important because that is identical with this interval. Very, very important. This is how you diagnose based on the shape of the P wave, and the following PP interval is identical with the normal PP interval. Okay, all right, let's continue. Okay, oops. Yes, okay, sinus tachycardia. Very similarly, we do have PPPPP, the identical, AVR negative, lead number 2 positive, the shape is the same, but it's faster than 100. Okay, this can be normal, but can be pathological one as well. So if you are in stress or if you exercise, if you do have any kind of emotional stimuli, relatively, you can have sinus tachycardia. But it can be abnormal. For example, if you have some kind of diseases, fever, hyperthyroidism, or embolism, or drug, a lot of other things that can cause the sinus tachycardia. Okay, very similarly, as you see here, we do see P waves, but and it's rhythmic, and we do see P in front of the QRSs, but the rate is around 120 or so. Okay, now, very, very important that the sinus tachycardia cannot be faster than a certain rate. And that rate is depending on the age of the people. All right, you learn that the rate, the normal sinus rate or the maximum sinus rate, if you do some exercise, you know that you can calculate it. 210 minus your age, and that could be around, let's see, the maximum rate that you can reach with the sinus. So for example, in my case, 210 minus almost that's 140, 150, but you can go up to 180. But you cannot have over 200 for sure. It's not a sinus rhythm. All right, this is very important. So based on the rate, you can guess whether that's a sinus or not. Sinus arrest, what does it mean? We do have a normal sinus impulse formation, but once there is no P. And another thing, it's important because if I erase, for example, these P's, maybe I can use again this, okay? So if I delete this piece because it's nothing, okay, that could be the interval. And if I had, for example, a rate of 60, now the rate is 30 here. Okay, so that's a longer. And it's exactly proportional to the normal PP interval. Okay, that's fine. However, in sometimes what will happen? Because the AV node again a nodal tissue and their own rate is faster than the half of the normal PP, so it's faster than 30, it's meaning that we do have an escape bit. So this is why relatively what you can see, only what you see that the P is missing, there is no P, not at all. No P, no QRS, and the next P is different one, and mostly you can judge that this is coming from the AV junction because the P be different, we will talk about later. Okay, go on. Okay, so this is what I was saying, that this is a multiplied normal PP interval, but a lot of cases we do have a premature escape bit that makes a little bit shorter. Okay, sinus bradycardia, again, there is a lot of things can cause normally or some other things. This is what it looks like. That's a sinus bradycardia, is rhythmic. P wave, the P is identical, positive lead number 2, negative in AVR, and that's on and so on. Now, sinus arrhythmia that can be regular or not regular. Okay, that's everybody has this respiratory sinus arrhythmia. It's can be normal, especially in young one. So during inspiration, if you take a deep breath, the frequency is getting a little bit faster, and you are exhaling, that makes a little bit slower. This is why the vagal tone is changing when it's coming from the stretch receptors from the lung, and that's will altering the SA node, and this is why it's going a little bit accelerating, slowing down. It has a own rhythm, and this own rhythm, this accelerated part, the rate is around 15 to 16, very similarly to the breathing rate. Okay, and another thing that can be non-respiratory when it doesn't depend on the respiration. For example, in elderly can occur that it somehow is not coming regularly and doesn't depend this fasting and slowing down on the respiratory rate. Now, another very important one, the sick sinus syndrome. When the sick sinus syndrome means that the ECG is basically the bradycardic and tachycardic periods changing. You can see some tachycardic period, you can see some empty, their line when you do have a sinus arrest, and after you can see, for example, sinuatria blocks, and this is what is called tachycardic bradycardic syndromes, and this is why relatively that's a sign of a problem with the oxygenation of the sinus. Now, basically, this sick sinus syndrome is associated with proximal tachycardias, tachybradycardias, and mostly it's caused by some heart problem. So you have to consider as a pathological sign. Now, this is what you do have with sick sinus syndrome. So this is arrhythmia absoluta. Maybe you remember what I said in the last time about atrial fibrillation, arrhythmia absoluta, no P wave. Here we do have arrhythmia absoluta, but we do have sinus P waves, okay? And the sinus P wave that you do see P in front of the QRSs, and this piece comes rapidly and maybe nothing. So arrest and tachycardic and bradycardic sinus period is coming each other. Okay. Now let's see the atrial impulse formation. Okay, that means the heterotopic impulse formation, and very similarly to the nomotopic one, we can have premature beat, we can have tachycardias, and so on. But we have a little bit more. For example, how do we know that this is an atrial premature beat? We know it because we do have P's in front of the QRSs, So always the P initiates the QRS. However, that P is not the same as a sinus P. All right, that's it. Now, these P's, that's abnormal area of the atrium activated and depolarize the whole atrium, it can be one area or can be more area. This is why we're talking about unifocal or multifocal atrial premature beats. As you see here, these premature beats, this atrial, we know atrial because we do have P in front of the QRS, and that's early coming beat and followed by a compensatory pause. And especially these P's, when we do have as a premature, is not the same. This is what is called multifocal one. And very importantly, this is a rhythmic one. For example, here, this is a rhythmic one you can see immediately. And after, let's looking at the morphology of the P's. Yes, we do have P, 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 P. As you see here, this P is not the same. And how can we prove it? Let's go down a little bit, okay? Because it's consequently recorded and this parallelly recorded is a 6 lead. Let's look at AVL. See, that's a big difference because in AVL, this has a little p and here is nothing. Okay, let's go to another one. All right, this is the same. That's a sinus. That's a sinus. This is not a sinus. So that's an atria premature beat. Okay, this is an atria premature beat again. And that's an atria premature beat. It's a couplet, as you see here, because the P is not the same as this beat. So this is a multifocal atria premature beat. Wandering pacemaker, okay, when the sinus is continuously changing or the depolarization wave is coming from the sinus to the AV and going back, and this is why you do have the P's constantly changing and going toward the AV, and after is going back. This kind of wandering pacemaker can be seen sometimes, and this is a variation, but it always means that some kind of oxygenation abnormality. Now, what the paroxysmal tachycardia means, I already said it. When we do have more than 3 consequently coming premature beat from the atrium, and that makes tachycardia, and because it started suddenly and ending 30 seconds before 30 seconds, and we do see P in front of the QRSs, this is what is called paroxysmal atrial tachycardia. Now, as you see here, the rate is over the normal sinus rate. It can be over 200. And the QRS is identical with the previous QRS, is narrow one, meaning that every ventricle activation taking through the AV junction. And this is very common things in elderly or in organic heart diseases or intoxication or hypokalemia. There are a lot of things can cause this paroxysmal tachycardia. But very important one, very important, when we do have this paroxysmal atrial tachycardia, because this is originated from one focus, and usually this is what we call as a re-entry phenomenon. I think you already heard in the lecture. This is rhythmic, faster than is rhythmic. Now, what will happen when we do have more than only one impulse formation center that originated from the atrium? That makes it arrhythmic because it's coming from different area, coming in different time. This is what is called arrhythmia absoluta with different P wave. That is called multifocal atrial tachycardia. That's very common one in pulmonary diseases, for example. This is how it looks like as a multifocal atrial tachycardia. If you looking at the P's, that's different one. Sometimes the best to look at the P wave is lead number 2, but sometimes in the chest leads in V1, V2. That's another good area to look at it. Atrial flutter. See, we are speeding up the rate of the atrium. So far we had atrial premature beat. After we had atrial tachycardia. Now we do have atrial flutter. What does it mean? It's meaning that the atrium is continuously contracting, relaxing, contracting, relaxing. There is no gap between, let's see, the relaxation and the next contraction, because it's continuously is doing this one. That is what is called atrial flutter. So we still have atrial contraction. However, this is a very fast going on contraction, especially if you're looking at the rate of the atrium, that is around 260 to 300 per minute. Of course, not every impulse can go through the AV junction, because the AV junction has this pause or a little bit slower rate or needs more recovery. This is why maybe every fourth, every third, every fifth going through. So this can be rhythmic, but it can be arrhythmic as well, but mostly is rhythmic. And you do see these sow waves. This is undulating wave. This is called the F waves. This is not a P wave, that's an F waves. This is how it looks like, as you do see the saw wave, and maybe how many? 1, 2, 3, 4, 1, 2, 3, 4, 4 to 1 conduction abnormality we have. So not every atrial beat goes through the ventricle, and this is what has a multiplication of this impulse. Atrial fibrillation. Now this is irregular impulse formation and chaotic one. There is more area, at least 3 or more area of the atrium is affected. And this meaning that there is no time for the atrium to be completely contracting, or the mechanically could be there is no contraction. That's only shivering. So this means that this cannot push out the blood. It's meaning that almost is a opening up, but the wall of the atrium is fibrillating. Now, and that's meaning we can have is fibrillatory wave, and that's very fast. It's around 350 and 600. However, they do apply a little filter, noise filter, to filter out the movement or electric noise and everything from the ECG. And this is why sometimes it's completely disappearing from the baseline, and you do see a straight baseline, but you do have arrhythmia absoluta, see, irregularity, and there is no P wave. That's very, 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 very important. Very important. So you have to keep in your mind, oops, I cannot. These two things, it's important. So first of all, we do have irregularity and no P wave. Okay. So far, we had arrhythmia absoluta with sinus P wave, that called sixth sinus syndrome. We do have arrhythmia absoluta with different P waves, that called multifocal atrial tachycardia. And we do have a arrhythmia absoluta without P wave. Okay, and this is what is called atrial fibrillation. Okay, atrial fibrillation is very, very important because that's very common arrhythmia, especially in elderly one. It can be younger, but elderly one, and it can cause a plug in the auricles and can cause embolization. So that can kill the patient. This arrhythmia absolute or atrial fibrillation is not important because we have a less cardiac output. We don't have less cardiac output. Because if you think a little bit what will determine the cardiac output, first of all, we do have the passive feeling. The passive feeling is what we do have in the end diastolic pressure in the ventricle and the difference between the venosus pressure. This will drive in about 80% of the blood into the ventricle. And at the end, we do have a kick of the atrium, that about 20-30%, that is pushing into the ventricle and stretching the ventricle wall, and that will give an additional 20% of blood to the ventricle and helping the wave to close when the ventricle starts to contract. What will happen if we do not have this atrial contraction? Basically, the venous pressure in the next cycle will increase. So we do have a passive drive, a little bit more than before, and that's compensate this missing atrial contraction. Now, however, one thing that the patient will sense, first of all, is a palpitation because the ventricular contraction is completely random. So the patient can feel that the heartbeats is not regularly coming. This is one thing. Another thing that the patient will sense weakness when he or the patient starts to do something, when the patient needs some cardiac output. How do we get this cardiac output, extra cardiac output? By increasing the sinus activity, by increasing the heart rate. However, the sinus is completely suppressed, so we cannot adjust the extra cardiac output. So when we are going up to the stairs or wants to run or do something, basically we cannot do it. And the patient feel weak, very weak. At rest, almost nothing. But when we need some cardiac, yes, the patient will feel it. Now this is how the atrial fibrillation looks like. Arrhythmia absoluta and no, let's see, P wave, or maybe you do see some, but the rate is faster than 350, and this is what is called atrial fibrillation. Okay, we went so far up to this point. Another next one is a junctional one. Very similarly, however, as you see here, the junction is a nodal tissue. Very similarly, we do have very similar arrhythmias as a nomotopic, as a sinus rhythm. We can have premature beat, we can have tachycardias, we can have escape beat, we can have escape rhythm, or we can have junctional acceleration. However, we cannot have fibrillation or flutter, all right? This only goes with the muscle tissues, atrium or a ventricle. So in atrium or a ventricle, we can have flutter and fibrillation. But in junctional tissues, such as the AV or a sinus, we don't have flutter and fibrillation. So keep in your mind. Now, how do we know that this beat is originated from the junction? First of all, the rate of this rhythm is slower than a normal sinus rhythm. So if we do have a escape rhythm, you know that these QRS complexes is very far from each other. The own rate of the junction is about 40 to 60. Very good. And this is exactly located in the middle of the atrium and the ventricle. And the impulse from this point can go up and down. And depending on the time, we can have, for example, a junctional beat that first activates the atrium and later on the ventricle. So the charge propagates faster toward the atrium than toward the ventricle. This is why we do have a P in front of the QRSs, but the direction of the P exactly the opposite. What does it mean? In AVR, we do have a positive P waves. And in lead number 2, we do have a negative P wave, but in front of the QRS complexes. There is another chance that when we do have a simultaneously activated atrium and ventricle. So where is the P? Inside the QRS. So there is no P wave at all. That's another possibility. Or first the ventricle is activated and the slower rate later on the atrium is activated. So we do have P and an opposite P, but behind of the QRS complexes. All right. So these are the different types of the junctional bits. For example, here, as you see here, this is an early coming bit, but the P is exactly the opposite way. So that's a nodal or junctional premature bit formation. And because every fourth one is a premature junctional bit, that is called junctional quadrigeminy. Okay, the escape beat, when you do see that, already mentioned it, more than 3 in a row and slower but regular, and or there is no P wave, or as we listed here, negative in front of negative behind. This is what is called junctional escape rhythm. Such as this one, for example, there is no P at all, you don't see anything, but the rate is very slow. Okay, paroxysmal junctional tachycardia. Yes, we can have it. We can have it. It's meaning that inside the junction, we do have this re-entry phenomenon develops, and we do have a very fast acceleration suddenly occurring, and the rate is 150 to 250. And one important thing, first of all, the QRS is narrow, period. Plus, the patient can stop this junctional tachycardia by applying carotid massage or taking a breather, the Valsalva maneuver, because the vagal tone can alter the junctional conduction, and this is why it's interrupting this circle. Okay, good. This is the junctional tachycardia, as you see, very nicely. In front of the QRSs, we do have negative P waves. Okay, junctional acceleration. Now, junctional acceleration, it's non-paroxysmal. It can be a sustained one and is still falling in a normal rate. So it's meaning between 60 and 100. However, you know that this impulse coming from the junction, because you do see no P wave, or do you see negative or front of behind, and the rate is falling into the normal rate. This is called junctional acceleration or idonodal tachycardia, such as this one, is still less than 100, but you do see that we do have P's in behind of the QRSs, so that's a junctional acceleration. Now, very important part is coming right now, and now that's a ventricle impulse formation. First of all, everything that is not in a ventricle, as you see here, including atrium, junction, sinus, that's a supraventricular impulse formation. And ventricle is right here when we do have an impulse that originated in a ventricle. How do we know that this impulse originated from a ventricle? Basically, there is no P in front of the QRS complexes, or there is no connection between the P and the QRS complexes, and that QRS is wide, and the T wave exactly the opposite as a main QRS complex. Okay, again, very similarly what we said about the atrial one, that ventricle premature beat can originate it from one focus, that's a unifocal one, or can be originated from a different areas. How do we know that? Because that wide QRS and inverted T is not the same. This is early coming, yes, it has a own shape. And that's an early coming, but that's a different shape. This is how we know that is a multifocal premature beat formation. Again, we can have bigeminy. Every second beat is a ventricle premature beat, so that's a ventricle bigeminy. Quadrigeminy, every fourth one is a ventricle premature beat, okay. Or we can have a couplet or triplets of a ventricle, the salves. Yes, that's a possibilities, okay. Now, it can have a non-sustained ventricular tachycardia. We can call it a paroxysmal ventricular tachycardia, doesn't matter. So non-sustained is less than 30 seconds is ending. And as you see here, it's rhythmic, but it's very fast, okay? So it's ranging about 140 to 200, and it's usually carotid massage doesn't help to stop it. And the patient doesn't feel so well because there is no rest between the ventricle activation. So the coronary circulation, when it's taking place during the diastole, it's very short. So there's almost no way to have a normal oxygenation of the ventricle. This is, for example, that's a non-sustained or ventricular proximal tachycardia, and coming back the normal one. Okay, we can have accelerated ventricular rhythm when the rate is falling into the normal rate, the regular 170, 80, but the QRS is wide, okay? And QRS is wide and it's rhythmic. This is what we called as a idioventricular tachycardia or ventricular acceleration, and usually occurs after revascularization, and this is not need to be treated. Ventricular flutter, very similarly to the atrial flutter, that is almost the ventricle is contracting, relaxing, almost simultaneously. So again, is no resting time at all. So relatively, this is very, very high energy needs for the ventricle, and usually this is cannot uh, be forever. So sometimes it's preceding the ventricle fibrillation, and ischemic heart disease, myocardial infarction, and so on and so on. This is what will initiate this ventricular flutter. And ventricular fibrillation, there is no contraction, only shivering. So what is the clinical sign? Patient lost consciousness because there is no circulation at all, no cardiac output. So this can happen, and that's if you are not doing anything, the patient will die because usually the brain damage occurs within 5 minutes, and after 10-15 minutes, the patient already dead. This is how it looks like. As we can start here, that's coming a flutter, and after is the irregular sign, fibrillation, and the isoelectric line, hydrogen. Now, there is another tachycardia, this called the torsal, the point tachycardia. Relatively, this is a polymorphic tachycardia. It looks like the electrical axis is changing bit to bit. And that's very important one because that needs some treatment immediately because ventricular fibrillation can develop. As you do see here, we do have a normal rhythm. After we do have some couplets, ventricular couplets, and after it looks like as a well, it looks like as a flutter or something. But however, the amplitude is changing. It's bigger one, shorter one, bigger one, shorter one. This is what is called the torsal, the point tachycardias. Parasystolia, well, it's common, but you won't have during the exam. It's meaning that we do have a parasystolic center inside the ventricle that is firing with their own rate. And this kind of impulse formation in the ventricle is insulated from the ventricle. So relatively, the other charges cannot discharge this area. However, it can affect the ventricle when the ventricle can accept the charge. If you're looking at this ventricle premature bit or ventricle bit, exactly has a 2 times, 3 times, so proportional to each other. This is how you know that is a parasystolia. And of course, parasystolia is depending on the normal rate when the patient has tachycardia or bradycardia, and sometimes you don't see it, sometimes you see it, and this how you can see it. Okay, and I don't want to talk. We are listening.
Okay. I found it a little bit challenging, even though I watched the videos. If I'm wrong, please correct me.
Of course,
But
I
I
will.
think that, I think the person, whoever this is, might have sinus arrhythmia because
Okay,
the
wait. Before you jump to the end, let's start from the beginning. All time we will start with rhythmicity. Is it rhythmic or not? This kind of tracing that you have usually include a rhythm strip at the bottom, maybe one or two, all right? Now, by looking at this long strip, you can judge whether is it rhythmic or not.
it's rhythmic.
I do not know because if you compare the distance, you can
Oh
see
no, no,
that,
no, sorry. It's not. I meant it's not rhythmic.
okay, this is
Okay, thanks.
irregular, so it's not rhythmic. This is one. Okay. Next one that you have to do, this is next is heart rate because this is a rhythmic How do you calculate the heart rate?
The rule of 10, I believe.
Okay, or you can go for example, 6 seconds or so. Okay, wait a minute. I try to. Okay, good. Let's see. 2, 3, 5. This is 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
In
1,
six big
2, 3,
blocks.
4, 5. Exactly 6 blocks. 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds. 1, 2, 3, 4, 5. Okay. This is 6 seconds. Okay. This is 6 seconds. And we have to count how many R we have. 1, 2, 3, 4, 5, 6, 7, 8, 9. So the rate, the average rate is 90. Okay.
Yep.
Okay. 90 beats per minute. Good. Now, okay. Next one.
Then I looked at the, oh, I'm sorry.
Why is it arrhythmic? Okay. Why is it arrhythmic? Can you point those beats that is out of order?
The third QRS, then the fifth, sixth
Okay.
as well.
Exactly. So others are rhythmic except these two. Okay. Now, one thing that you can see immediately, this distance is shorter than this one, okay? This distance is shorter than this one. What kind of beat is this one when you do have a short, long, short, long? So this beat came earlier. If a beat came earlier, that's called premature beat, yes?
Yeah.
Okay, so now we know that this is some kind of premature bit. Okay, now we have to rule out what kind of premature bit is this. First of all, the QRS is narrow, the same. So the shape of the QRS did not change, meaning that it has to be a supraventricular one, yes? Because the
Yeah.
ventricle activated to the normal conducting pathways. Okay. Do we have P wave in front of the QRS? Yes, we do. Okay, we do. Next question. Is this P the same than another normally coming P's? I
No.
do not think so. Okay, now here is another one that is not normal. So they are not. So it's meaning we do have a atrial premature beat, because not a sinus one. That's an atrial premature beat. This is one thing. So next one that you have to do, compare the shape of these P's. Compare this to this.
The second one is a lot higher than the
Okay,
first one.
so the shape of the peas are not the same. What does it mean? It means that it is coming from different areas of the atrium. Because if they came from the same area, they should be identical. However, because they're different, coming from different sources. So this is a multifocal atrial premature beats. Yes?
Yeah.
Okay, good. Now we figured out. Next one that left is axis. So far we do not know anything, but you could say that, okay, the duration of the P, the PR, duration of QRS, QT interval, T wave, and so on. So, but so far nothing. Let's look at the axis. Lead number one, positive. Yes?
Yeah. Yeah.
Okay, so lead number one is positive. AVF is
ABF is positive.
well, or equiphasic, yes? We can say
Yes.
that AVF is about 0, so I mean 0. What does it mean? AVF is 0 or at 0 or at what you have, 180, okay? One is positive, so it has to be this one. So the axis is 0, so it's normal, that's 0. All right?
Okay.
Clear?
Yep.
You got it. Okay, good. Let's move on. 102. Who has 102? Anybody? 103?
Yep, that's me.
Okay. You want to
Okay,
share it or keep sharing? I can keep
uh,
sharing.
if you can keep sharing, I can
Okay.
share if it's a trouble.
It's whatever you
Um,
want.
okay, so we said that we start if that's a rhythmic or not, right?
Yes.
So it is a regular arrhythmic. Like
Mm-hmm.
we see constant gaps between the
Mm-hmm.
arrays.
Mm-hmm.
But if we count the blocks, we can see that it's almost 3 blocks, a little bit less than 3 blocks. So it
Mm-hmm.
means the heart rate is around 110, 120,
Okay.
which makes it tachycardic.
Mm-hmm.
Um, we can also see that we have normal P wave.
Mm-hmm. Very good. So we have
Um, we
P
have
wave,
sinus, and it's also regular
positive.
arrhythmia.
Okay.
Yeah, positive.
Positive in two and negative in AVR. Okay. So
Yes. Also, we know that it's a little bit. It's between 0 and 90.
what axis you are talking about now?
If I look at lead number 2,
The number one
lead number 1, sorry,
and
between
AVF.
and
This is what,
AVF. So
okay.
both are positive.
So the axis is
Um,
between 0
0 and
and
90.
90. Okay.
Yeah. And then if we look at lead number 2, which is a
Lead
little bit
number
more than.
two, no, no, okay,
Okay.
you can go
Mm-hmm.
for this one, lead number two, but one thing that you can judge it, the best one, choose a lead
Mm-hmm.
that the perpendicular of the lead falls in this area. There are two leads that falls in this
Mm-hmm.
area. One lead, that's an AVL, okay, AVL.
Mm-hmm.
AVL exactly perpendicular to 60, okay, lead number two.
Mm-hmm.
All
Yes.
right, this is one. Or another one that you can look at, lead number three, because lead number three perpendicular to 30. Okay, now
Mm-hmm.
let's see. AVL is positive,
AVL
yes?
is positive. Yes.
So we are somewhere here, okay?
Mm-hmm.
Lead number three is positive, okay?
Positive slash.
Okay, so it's
Yeah.
meaning that we are somewhere here.
So somewhere between 30 and 60.
Exactly,
Yeah.
exactly.
Okay.
But it's still normal. Okay, good.
Mm-hmm.
Very good. Nothing else so far.
Thank you.
Okay, good. Very good. 100 and, oops, wait a minute. 104.
That's me.
Very good.
So first I looked at the rate,
Mm-hmm.
and so I used the rule of 300 because the beat looks quite regular.
Mm-hmm.
So I found between each QRS complex there was only like 1.5 boxes. So
Mm-hmm.
I would
Mm-hmm.
say it's around about 150 to 200 beats per
It's
minute.
close to 200. Okay. What does it tell you if it's close to 200?
It's tachycardic.
Yes, it's for sure, but what else it will tell you?
I'm not sure.
Okay, the sinus tachycardia, how much can be? I said it, this is why I recorded again or said again this little introduction. Sinus tachycardia has a maximum rate that depending on your age, 210 minus age. And this is close to 200, so I don't think that is a 10 years old who has this one. So for that cannot be, or close that you cannot be a sinus tachycardia right here. What else proving that this is not a sinus tachycardia? Do you have P waves?
I think I have F waves
No, no,
because
no, 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 no. Let's magnify a little bit. Okay, I'm going to magnify it. Oops, not this one. 100 and which one that we are looking? 104. Yes. Okay. Okay. Let's look at this. What kind of wave is this one?
P waves?
That's T wave. A T wave is always bigger than a P wave. And if you do have a QRS complex, you have to have a repolarization. You have to have T waves. That T can be negative, positive, or anything. But as you see here, that's a T. It's not a P wave. Okay? That's a T wave. So I would say that there is no P wave. Again, that is going to support that this is not a sinus rhythm. So first of all, the rate is too fast and there is no P wave, but the QRS is narrow. So that's a supraventricular tachycardia. Okay? Because the QRS is narrow. So we can say, yes, that's a supraventricular tachycardia. Possibly is a paroxysmal one because it's change, it's a very rapid one, and nobody likes to have a rate that is close to 200. If you had flutter wave, it should be sour waves. We have some later on. Okay, so that's a supraventricular tachycardia. This is what you can state. All right.
Okay.
Axis?
So the axis, I looked at lead 1, and which is positive, and AVF, which is also mostly positive.
I
So
would say
it
about the
should be,
same, not about the same. About
they're not the
tachyphysics.
same.
But
Oh, okay,
no.
fine.
Well, we have 4 up and we have about 4 down. So I think it's perpendicular, which is perpendicular. That has to be around 0. Yes?
Yes.
Okay, good. All right, next one, 105. Anybody? 106? Nobody. If not, I'm going 107. Okay, if nobody has this kind of tracing, I would say these are the F waves, capital F waves. Okay, these are the flutter waves, flutter waves. So this is the atrial flutter. This looks like an atrial activation is a so pattern, and maybe every 8 or every 5 or every certain bit is going to conduct it. Such as here is a slow one because that's a bradycardic one, but still an atrial flutter. Here, a little bit faster, it's changing from 2 to 1 to 4 to 1, and this is arrhythmic. So a flutter can be rhythmic or arrhythmic, but you do see these flutter waves, okay? These are very nice sound waves. Okay, so this is the atrial flutter. Good. Okay, let's move on.
Can I ask a question?
Yes?
And I'm sorry if it was part of the introduction report. Like, what is the clinical meaning if the flutter is rhythmic or not rhythmic? If the flutter itself.
Okay, the flutter itself is important. Basically, let's look at, I try to show you, watch the videos, okay? I try to show
No,
you.
I understand what the flutter is. I mean, if it has a constant what did he say?
Contraction, relaxation, okay, continuously.
Mm-hmm.
There is no rest between the two cycles, all right? So relatively, this is how the atrium works. It's not good, but it's still contracting. It's pushing out all the blood, okay?
Yeah.
Now, a fibrillation cannot because it's shivering, okay?
Mm-hmm.
So there's no active contraction. That's it. So what is your question?
I'll try and rephrase it for the next class, maybe, or look it up.
Okay, you
I'm
are
not sure
asking.
exactly how to. I have an idea of something, and I don't really know how to phrase it.
Okay,
So,
I'll try. Okay, maybe the conducting ratio. All right. Now, you do have an AV junctional delay, yes? Because the nodal tissue has a longer refractor period, okay? So it's meaning you need more time for the AV junction to conduct the charge. That's good because this way, not every fast charge can go through the AV junction. However, when you do have a flutter. Relatively, that's proportionally can be conducted. So this is why 4-to-1, 3-to-1, 2-to-1 conduction can occur. And depending on the oxygenation or the quality of the AV junction, you can have a faster or slower one. But mostly they are rhythmic one. However, if you do have an atrial fibrillation, this is so fast, about 300. So it's firing continuously to the AV junction. And when it's some tissue, some nodal tissue already repolarized and could accept the charge, however, that is not enough to conduct through. And this always, you are going to disrupt this kind of repolarization. Relatively, it's almost impossible to count that this AV junction can conduct or not. If you are younger, your AV junction has a shorter refractor period. This is why in those who is young and getting atrial fibrillation can have tachycardia very easily, very fast tachycardia. In elderly one, however, can develop bradycardia because the refractor period of the AV junction is longer, all right? But usually in flutter, we do have rhythmicity. Not all the time, but has a higher chance that we do have rhythmicity. However, in AFib, never ever, okay?
Okay, yeah, that's my question. Thank you.
Okay, 108,
Yes, that's me.
okay?
So we check first the intervals between rhythm. So it's regular rhythm.
Mm-hmm.
Then we check in the heart rate.
Mhm.
There's two big large squares between RR interval. So it's gonna be 150 beats per minute.
Okay,
Then we gonna check the P waves, and we see there is no clear P waves in, for
okay,
example, in
very
the lead
good.
one. So there is the signs of the atrial flutter,
Atrial
flutter,
fibrillation.
fibrillation.
Okay,
Voice.
if you had flutter, let's go back to this one. That's flutter wave. See? That's flutter wave. You can see some sound waves. If you go for a faster one, you still see this kind of flutter waves. But when you do have fibrillation, there is no P wave. You don't see a big piece. Maybe you can see some kind of atrial waves, such as, for example, if I go down here, okay, for example, here, it's not a clear atrial activation, but I would say that possible these can be.
Mm-hmm.
But morphologically not the same, but it's very fast. It's much faster than 300. So this is why you can say that is AFib, okay? Atrial fibrillation.
Atrial fibrillation, okay.
Okay, go back, okay. So that's an AFib. And go on.
Then the lead 2 or lead 1, we're gonna look at the lead 1. It's mainly positive. And look at the AVF.
Okay.
So X is gonna be between 0 and plus 90 degrees.
Okay.
Normal axis. And so the positive gonna be lead 1, 2, 3, AVF, and only negative will be AVR, which is gonna be only strongly negative.
Okay, but one thing, one is positive. AVF positive is between 0 and 90. Now you have to choose another lead. Look at AVL or lead number 3. Lead number 3 is positive, yes?
Positive, yes.
Okay. That meaning lead number 3 is 30, okay? And that should be somewhere here. AVL
AVL is only
is almost the same. So again, we are at 60. So this is, it can be between 60 and 30.
Okay.
Okay.
Yes.
All right. Good. 109. Anybody? Very similarly, arrhythmia absoluta, no P wave. Maybe here you can see some teeny tiny noise or something. In V1, that's the best one to look for the atrial activation. Okay, so again, that's an AFib, atrial fibrillation. And if you are looking at the axis, is positive, negative. So this means we are somewhere here, okay, somewhere here. Look at lead number 2. Lead number 2 is minus 30 and 0 because that's positive. It meaning that is between 0 and minus 30, okay? All right, and of course it's a arrhythmic one, but this is normal rate. I could say that. Okay, 110.
Hi, Professor.
Okay.
I calculated the heart rate. It is
Rhythmic or not?
arrhythmic, sorry. It is arrhythmic, and I calculated the heart rate, and it's about 150.
Mm-hmm.
It is in the normal range because lead 1 is equiphasic, and the perpendicular lead, which is AVF, is also positive. The P wave is positive in lead 2 and AVF, so
Wait. So it's meaning that's about, you said this is positive or 0. Okay, positive or 0, the axis, okay?
yeah,
AVF is positive, so it's meaning that it's around 90 degrees, yes?
yes,
Okay, all right. Now, but comparing lead number 2 and 3, okay, lead number 2 is bigger one, so I would say that this is a little bit less than 90, it's around 80, okay?
okay.
Okay, go on.
The P wave is positive and lead
P, do we have P waves?
no.
Why do you say that is positive and negative?
Oh,
Okay, basically, if you are looking at these leads, okay, let's look at, for example, lead number 2 at the bottom. Okay, let's look at this one. Well, that's a T, that's a T, that's a T, that's a T. These can be some kind of wave, what we do have here, see, these, or maybe here. Look at V1. Oh boy, look at that one. Again, this is faster than 300, 350. So what we do have here?
I'm not sure.
Yes, you should. Arrhythmia. You said arrhythmia absoluta. No P wave. So atrial fibrillation. Let's keep in your mind. Arrhythmia, no P wave, or if you do see some P waves or looks like a P wave,
It's irregular
at
waves.
irregular, that means atrial fibrillation. The P wave should be symmetric and equal to each other. That means sinus, but this is not, and very fast. This is why it's AFib, okay? That's arrhythmia absoluta. And without P wave, because that's a fibrillatory wave, that means atrial fibrillation. Good. Okay, 111. Nope. 112.
Hello, Professor.
Yes.
Okay, so I looked at the ECG and it was rhythmic.
Mm-hmm.
I counted the heart rate and it was 3.5 blocks between
Mm-hmm.
our waves, so it was around 85 beats per
Mm-hmm.
minute.
Mm-hmm. Mm-hmm.
I checked the axis, I checked lead 1, it was positive.
Mm-hmm.
AVF was also positive, so
Mm-hmm.
it's in the normal range. Then I
Mm-hmm.
compared lead 2 and 3, and 2 was bigger.
Mm-hmm.
So it should be around 80 degrees.
Well, I would say that not 80 degrees because let's look at if lead number 1, lead number 3, okay, and this is lead number 2. You said lead number 2 is the biggest one, okay? So it's meaning that it should be close to 60, yes?
Okay.
Compare lead number 1 to lead number 3. I would say about the same.
Yeah.
So that means 60.
Okay.
But if you go for AVL, isoelectric one, so it's meaning perpendicular. So because that's 0, it's meaning that is 60 degrees.
Okay.
All right, go on.
And then I didn't see any clear P waves. So I thought it was atrial flutter.
That's a SAW wave. See, but you still see some waves, okay? You
Yeah.
still see some SAW waves. Okay, this is the flutter waves. Do you see, because a big one, undulating one, so that's a flutter wave. So this is why you say that this is a
Atrial flutter.
atrial flutter. Very good.
Thank you.
All right. Okay, 113.
Hello, Professor.
All right.
So when I looked at the ECG, it looked rhythmic.
Mm-hmm.
And when I did the heart rate, so it looks around 2.5 boxes. So it's around 120 BPM, which means there was tachycardia.
Mm-hmm.
When I looked at lead 2, I was a bit confused, but is this inverted P wave?
Yes.
Right? Yes. So I
Yes.
said inverted, yeah. So I saw inverted P waves before the QRS.
Mm-hmm.
I was thinking it could be the proximal junctional tachycardia or
Very
supraventricular.
good.
I was confused. Yeah.
Very
So
good.
it's
That's
the
a
junctional.
junctional tachycardia. Exactly. Very good. Junctional tachycardia. Okay.
Yes.
Axis.
Yes. And then I looked at lead 1. Lead 1 is positive, so the axis is on the left side. Then the AVR is negative, so it's normal deviation. AVF is also positive.
Yeah, okay, one positive, AVR positive, no more. All right, that's it.
No
No
more,
more.
yes.
Immediately
Yes,
you can
yes.
say. And AVL is negative, so it's meaning that the axis is located between,
The
for sure is less than 30, okay?
yes.
Less than 30 and more than 90. Let's look at lead number 3. Or not lead number 3, AVL. AVL, okay, AVL opposite 60, I'm sorry. So you are between 60 and 90. Okay, because AVL is negative, AVL exactly perpendicular to 60. I have to delete. Oops, I'm going to delete this one and I'm drawing nicely. So that should be perpendicular, okay, to 60, all right? So that's AVL. AVL perpendicular to 60 and is negative, so it's meaning that less than or more than 60, but less than 90. So you are between 60 and 90. It's still normal. Okay.
So when I was doing that, what I was confused is that after the inverted P wave, there's still like a little bit elevation. So when I was doing this, I was confused if that the little elevation is the P wave or the inverted is the P wave.
No, that's inverted. This is an inverted P wave, meaning that, as I said it in this video as well and another video, that the impulse formation center is in the middle between the atrium and the ventricle. And the impulse first activates the atrium and later on the ventricle. So this is why if you're looking at, for example, lead number 2, one goes away, meaning in lead number 2, we do have a negative piece. And after we do have the QRS complex. Okay, and we do have a T wave. In opposite, in AVR, pardon me?
Sorry, I was like, how do I differentiate between the supraventricular and the junctional? I
The
was a bit
same,
confused on that.
supraventricular and junctional, the same.
Okay, okay.
Supraventricular means that everything above the ventricle, including AV junction, including atrium, including sinus. The common one, the QRS is narrow. All right, so if you are looking at a supraventricle, okay, supraventricle, it's meaning the QRS is narrow and the T is proportional to the QRS complex. Okay, so the same direction that you do have the T and the QRS is. If you have a ventricular one, you do have a wide QRS complex and an inverted T wave, okay? Exactly the opposite of the T wave. Ventricular can start the QRS negatively, but the T is opposite, okay? These are both ventricular one, and this is supraventricular one. It can start here, doesn't matter. It can start something like this, and that can be a supraventricular one because the QRS is narrow, okay? All right, wait. 114.
It's me.
Okay.
So it's rhythmic, and the heart rate is 30, 100 divided by 40 for like 4 blocks, so it's 75 heart per minutes. Lead 1 is positive, AVF is negative. So we go to lead 2. Lead 2 is negative, or I think so. And AVR is positive, so it's between minus 60 and minus 90 degrees.
Okay, so the axis is in a negative range, and AVR, it's about 0 or so. So that's about minus 30 and minus 60, between minus 30, minus 60. So that's a extreme left deviation, but that's a ventricular rhythm. It can be anything. All right.
Yeah,
It doesn't mean a lot
because
of things because the impulse is originated from the ventricle.
yeah, because the QRS is wide.
Exactly. And the T, the repolarization, exactly the opposite. See? Exactly. Good. Very good. So that's a ventricular rhythm. You can see it as a ventricular acceleration because the rate is around 75 beats per minute. So that can be an acceleration. Okay. 115.
Hello, Professor. So I think mine is rhythmic because between each R wave is like around three boxes. So I think the heart rate is around 90 beats per minute. And observing to find the axis, even though it's not so clear, I think lead 1 is positive. And AVF is positive too. So I think it's in the normal range.
1 is 0 or positive, okay?
Okay.
AVF is negative. You have to be here.
Okay.
Between 0 and minus 90, okay?
Okay.
Another lead, you should look at lead number 2, because lead number 2 is exactly perpendicular to minus 30, okay? And you can see that this is negative. So that's an extreme left deviation. Look at AVR. AVR is positive, okay?
Okay.
Where can you have AVR positivity? That's ups. Sorry, that's 60, okay? So you are somewhere here between minus 60 and minus 90. So that's an extreme left deviation.
Okay.
And do you see any P waves?
No, there are no P waves.
So again, that's a ventricular rhythm or ventricular acceleration that we had before, okay?
Okay.
Good, very good. 116. Anybody? 117. Okay, that's bradycardia for sure. Later on, that's a conduction abnormality as well, so we don't need to discuss right now. 118.
Hello, that's me.
Yeah, that's an interesting one.
Yes, just before I start, I think I need to do this one quick because we have class in 14 minutes.
Okay.
So I just I saw like a arrhythmia. So arrhythmia absoluta.
No.
No.
No. Arrhythmia absoluta, you can see this arrhythmia absoluta, but somehow we do have some rhythmicity. Can you see here?
Okay.
And we do see P waves, okay? We do see P waves.
Yep. Okay.
Whenever we do have QRS complex, we do have P waves. Where we do not have any P waves, we don't have QRS. So that can be a...
So no P waves.
So there is no sinus activity.
No
So
sinus
that's a
activity.
sinus arrest, for example. It can be a sinus arrest.
Okay.
Or can be sinus pause or whatever you can say.
I see. Okay, so
All right.
and an atrial fibrillation, would that be there because of these?
Atrial fibrillation, if you do have an arrhythmia absolute and no P wave, no P wave, now that can be atrial fibrillation. But here we do see P waves.
Okay. So we see
All
P
right.
waves.
Okay. And the axis is positive. Positive is a normal range. Lead number 3 is about equiphasic, so it's meaning that's around 30 degrees. Okay.
Okay. I see.
Good.
Thank you.
You're welcome, and you can go.
Bye.
19. Anybody has 19? Okay, if not, let's see, 120. Nope. 121. Can anybody tell me what is this? That's a ventricular flutter. Yes, that's a ventricular flutter. Okay. 122. That's a ventricular fibrillation. Yes, ventricular fibrillation. Okay. 123. That's a ventricular tachycardia. Okay. Which is the last one? Which is the last one?
Non-sustained.
Yeah, that's a non-sustained. Okay. But what else? Who has another number? Because I think it's almost the finished view. Who has some ECG tracing? Who left out? I can check it. Let's see, what is the last one? I want to check what the last one is. 126, Emily? Emily is not here. I want to show you 125, for example. Oh, I have to share. Okay, I'm sorry. I stopped sharing it and okay, good. 126, see? This is the dorsal, the point tachycardia. Very nicely, you can see that this undulating, the QRSs are different shape, and that's the dorsal, the point tachycardia, what we do have here. Okay, what else we have? Okay, 127, 127. That's, if you do see, we do see, for example, P waves. Yes, it's arrhythmic, but we do see P waves, and these P's are identical, but you do see some slower coming, faster coming, slower coming. So that's a sinus tachycardia, or you can physiologic arrhythmia as well in this situation. And let's see, what is the last one that we have here? Okay, here you can see that every second beat is a ventricular premature beat. So that's a ventricular bigeminy. Okay,